So it's week 7 already. You just had your second exam. Remember, next week is the project. It might be the end of this week, a good week to turn in some portions of it so I can look at it, correct it, send it back so you can get the best grade possible. It is 6% of your grade. You do not have to choose one of those diagnoses in the list that's in your modules. You might have another one that your family member, your next door neighbor, somebody you know had, and you want to know more about. And that's fine. Just let me know what it is. Most diagnoses can be related to children also. So if it's something you're interested in, just let me know. This week you do have one CJ Sims and you have one discussion number 5. I did get your discussion questions graded. And again, the one thing I'm seeing is you're not putting in parentheses the citation, which means like Perry, comma, 2023, somewhere in there, which is showing me that's where the information was. Or maybe you got it from the CDC and there is no date, so it's comma N period, D period, no date in parentheses. And this is something as you go further in your degrees that you're going to need to have. So I call it out, I show it to you. If you want help getting it to get your 20s on these instead of an 18, just let me know. I'll show you quickly. It's not a big deal. So PowerPoint. I have a PowerPoint slightly less slides than what you got, but it's the same information, all right? Because I want to be able to get through all of this for you today. This is cerebral and it's endocrine. An endocrine is your DKA and, a lot of different things. So I want to make sure you get your information. Again, I will be sending Monday's class with that cahoots there. So in infants, increased intracranial pressure could be due to many reasons. It could be due to hydrocephalus, could be due to some trauma, could be a fall, etc. And what it is, it just increases all of the pressure in there and pushes on the brain. And one of the first things that we see is a decreasing level of consciousness. In a smaller child, it might mean that they're getting sleepy, all right? Especially those who cannot express themselves. Very difficult to figure out infants, but there's little subtle signs. There's all different places where you can swell the picture from your book to show it to you. Now, in infants, what do you see when you have what we call a neuro baby or one that's having hydrocephalus or something going on in the brain? Well, they have a headache, if you can imagine. So they're irritable, they don't feed well, and they have a distinctive high pitched cry. You can walk into a nursery of 30 babies all crying, and you can pick out the neuro baby because it's a higher pitch. It's like nails on a chalkboard. It really is that distinctive. And you cannot calm them down. I could soothe any child and put them to sleep. I'm a baby whisperer. Neuro babies are very difficult to soothe. Pacifier, wrapping them up, rocking them, nothing works. And that fontanelle is so great in infants for your assessment. Is it flat? Is it bulgy? These things will be like a trampoline and round and peaked, and you'll see it. And you see the picture, those scalp veins? They are huge because of the pressure that's putting out. Pressure also goes to the eyes, so the eye's going to have sun setting. You're going to see all of these things. Now, older children, they'll complain of headache, and you're going to see vomiting not related to eating. It's not like a little GERD spit up. It is more of a more severe throw up. And then, of course, you can get into because of pressure in the brain. Where's that pressure going? Seizures, drowsiness, lethargy. And these kids now don't know what you're saying. They don't know how to sit, stand. They don't know what you're telling them. They get confused. Simple commands they don't do. Now, if you get to the point where the heart rate is slow, remember the brain stem is in the back of the head, right? Fill it up with fluid, it's going to press on the brain stem, right? What does the brain stem control? heart rate, right? Pulse, respirations, temperature. You're going to see that heart rate go down. Then you're going to see them not responding. You're going to see pupils different. It was a great picture here I showed you. You see one blown pupil on a child, infant of any age, it's a neurological emergency. That needs to be told to the physician immediately. And then if it gets to the point where the pressure's getting too much, you're going to see that seizure, extension, posturing, you're going to see that going on. And it gets to the point of coma. So it goes from awake and alert all the way down to the lethargy, and then it goes to obtundation. I mean, we'll see children come in, let's say they've fallen on their head off a second story balconies. And I've seen actually more than one, and they're not waking up. You even actually take and do a rub on their chest or even nipple pinch, and they're not even moving. They're really in a coma. And that's to the point that most likely they'll be persistent vegetative state. Now, as a trauma nurse, I used to always have to do these Glasgow coma scales. And this is on arrival. What do they look like? And what does this measure? It measures the pupils, the eyes, and the motor. And the biggest one that you can have is a 15. So why is this important? Well, we get the call from the rescue, the helicopter bringing in whatever. This Glasgow coma scale of 3. Well, this is just that they're there because everything else is not working. That says, I need neurosurgery, surgery, x-ray. I need everybody I can get in there to help me. This is an extremely sick child. Conversely, they say Glasgow coma score of 13, I'm okay. It's not going to be that severe. If I know it's a head injury, I'll reserve the CAT scanner for me. But you can see how it's so important. Neurological exams, vital signs is going to show you a lot, whether heart rate high, heart rate low. Look at the skin, the eyes, pupils, how are they moving, posturing, their reflexes, do they have any reflexes? All of these things shows you a lot. And there's pictures of all the eyes that you can have. The cerebral, the corticate, and this is the different types of seizures and positionings you'll see. Now, let's say you see a child, that comes in and you know that they're going to have increased intracranial pressure, and you start maybe an infant, you see the fontanelle going, or you see an older child where their level of consciousness is decreasing. They're going to do, of course, labs, always looking at those electrolytes. Those make a lot of difference with fluid balance, okay? You're going to have an EEG that measures electrical activity of the brain, and you could see seizures and stuff going on. They do a lumbar puncture, and instead of just getting fluids to examine, they'll measure the pressure of the fluid. They put, like they did when I first started nursing, a glass manometer gets connected, and we watch that cerebral spinal fluid go up, and we will have a number. And from that number, we know, is it very high pressure or is it okay? So sometimes that's telling us what's going on before we even do a lot of these testings. Of course, a CT scan, any fractures, any accumulation of fluid we can see, and then MRI. They usually, if they know head injury, they go right to CT scan. They don't even go to X-ray. They'll do the rest of the body. But head injury, we need to figure out quickly so that we can take care of it. Now, taking care of an unconscious child is tricky, whether it's a child or adult, to tell you the truth. They are tricky. Always, always number one is airway. We know it. And we want to do, especially these children that have had a head injury, to do everything to reduce that intracranial pressure. And of course, if they're in shock, we need to treat it, but we need to treat it very carefully. Level of consciousness we look at, pupils we look at, and then sometimes in the ER, I'll do vital signs every 5, 10 minutes, 15 minutes, then 30 minutes. They go up to the ICU, and it's every hour, every half hour, depending how unstable these children are. And then the maximum amount of time, especially in the first day or two, is every 2 hours. You're documenting neurosigns. So you got this child, that has neurological injury. They're comatose at this point. Number one, we manage the airway. But what's interesting about the airway, we can control cerebral blood flow, dilatation, and constriction. So if we let that child not breathe good, it retains CO2 and it causes vessels to open, increasing the intracranial pressure. But we can hyperventilate, we can blow off CO2, and we can keep that pressure down. So just by ventilating, we can do things to decrease pressure. We want to do everything to prevent gag and cough and suctioning. And then, we need to, once a shift, go down the endotracheal tube, make sure it's clean, but we're not going to overly stimulate it. So what are you going to do intracranial pressure monitoring? We call them a lot, we call it the bolts going in. And what it does, it goes right into the brain and it measures pressure. One of the things about this is it's constant on the monitor, like an arterial blood pressure. So there are that one that was just a catheter. This is the bolt here, the one on the right. And these are the places that we stick those things, depending on the child, depending on the injury. Now, one of the things as nurses, we need to do nursing care. We do turn, we do position, but we do it a lot more gently with a child with increased intracranial pressure. Make sure that neck is open. We want blood flow. I always put a blanket roll under their neck, keep their neck open the way it should. The head of the bed, they're going to tell you, keep the head of the bed at 30 degrees. Don't change it. Okay. And then, of course, doing all those things that doesn't increase intracranial pressure, like suctioning, like touching them, turning them too much. Those things do cause them to have increased pressure. And this would be a kid, if we had a private room in the ICU, this child would go there because all that noise stimulates them and could cause them to have increased pressure. Even if they're paralyzed and sedated, it still can affect them. Now, one of the things with intracranial pressure is strict intake output. Because if we put too much intake in that child, it's going to cause more swelling in the brain. So we have to be careful not to overhydrate these children. Nutrition is always important. We need nutrition so we heal. We need nutrition to grow. I think you've heard me say it 100 times already. Nutrition, 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 right? So if these children are going to be comatose or obtunded for a period of time, initially we'll put an NG tube down and we'll give slow feeds in there just to get the nutrition. It won't be just hyperal and lipids and that whatnot. They're going to want other nutrition in there. And always, yes, we're going to monitor for aspiration, making sure that we check for, if there's any residuals in the stomach as we're feeding these children, etc. So when caring for an unconscious child, an appropriate nursing intervention is to what? Read them carefully and tell me what you think. We're talking unconscious child, increased intracranial pressure. What's your biggest concern of these?
C.
It is C. Yes, it is. Monitor intake output carefully to avoid circulatory and fluid overload and that increased pressure. Okay, endocrine system. We have pituitary, we have a thyroid, a parathyroid, and we have adrenals, all right? And there's 2 lobes of pituitary gland. You need to keep what does what separated, okay? Pituitary gland is either growth or it is fluid balance, as in diabetes insipidus, or syndrome of inappropriate antidiuretic hormone, and then it's growth, all right? 2 sides. Anterior is growth, posterior is a fluid balance. So knowing that, all right, so we have sometimes a problem with too much or too little growth hormone. Now, when you have hypopituitarism, they're talking about, of the pituitary gland and growth. There are things that we can do. Now, one of the things we do need to ask these parents is your family short normally? Because there are some families that everybody's 5 foot tall. So to have a shorter child is not abnormal. To have them grow, the growth hormone's not going to work because hereditary wise, they're not given that growth. Like my family, I'm 5'7". My brothers are 6 foot. My father was 6 foot. So if I was 4'6", then that would have been a problem. And what do? We do give some growth hormone. And growth hormone, to be placed on it, they do it until the child stops growing less than 1 inch per year. So they can get a lot of height with these children. And this growth hormone is like giving insulin. They've got to give subcutaneous injections. So it is a commitment by parents and children. Now, hypopituitarism does a lot of things. It does cause, but mostly we talk about the growth in these children. Now, one of the things, and they say here that when it stops growing, it's girls about 14, boys about 16, because boys tend to grow later than girls. My son, for instance, when he was 16, he was 5'7". He went off to the army, and at 21, he was 6'4". So somewhere in there is when he grew. But again, so growth hormone, subcutaneous injection, we give it up to when they stop growing less than 1 inch per year, and usually it's 14 and 16. Now, hyperfunction is gigantism. You've seen some, movies with these really tall 8 foot people. They were the person who had too much growth hormone on them. This guy down on the right used to be the horror guy in all the horror movies, and he was 8 foot tall growing up for me. But they do have distinctive features, and that's why I put it there. Many times, this is due to a pituitary hormone tumor on the pituitary gland. And what they do is they go up the nose and remove that lobe of the pituitary gland, and we stop them from growing. So we can give all sorts of things, to them after surgery. Because once we remove that lobe, they're going to be deficient. Let me see. So again, with this hyperfunction, these children, they're going to be made fun of, right? You've got the little short kid and you got the really tall kid, and they'll be made fun of. So again, being there for parents, being there for the child is a big thing. Now, precocious puberty. Now, I put two pictures here. If you can imagine, I don't know if these are doctored or whatnot, but precocious puberty can be something that can create a lot of teasing by the other children. And what we say precocious puberty is when they have sexual development before the normal time, before 9 years or before 8 years in girls. Boys might get a beard and girls might have breasts. And the problem with these is, again, they're not like the other children, and they are going to be teased and they are going to be self-conscious. And we can put them on stuff to stop that from happening. Lupron is actually the name of this one. And we can get them to where they need to be before they start with this precocious puberty. So again, this medicine is given. We keep them slower. We slow them down until they should be going through, getting their menses and growing their breasts, et cetera, et cetera. Now, the other lobe of the pituitary gland, diabetes insipidus, or DI as I call it, or SIADH, syndrome of inappropriate anti-diuretic hormone. DI is too much. SIADH, too little. So when you have too much diuretic hormone going into the body, what do you see? I'm thirsty, 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 and I urinate, urinate, urinate. What is interesting is infants can have this, and they cry and scream and want more and more milk, and they keep drinking, drinking, drinking. But give them a bottle of water and they're satisfied. So that's one of the clues that it's diabetes insipidus, okay? And you can see here, it doesn't matter how much fluid they get in, they're still going to be urinating. So you can imagine you're going to have all of these electrolyte problems with it, and you're losing volume, and it can go on and on, all the things that can happen. So what do we do with it? One of the things we can give is a vasopressin. Vasopressin is given, sometimes there's a nasal spray, sometimes it's given IV, sub-Q, IM, and this is life. This is something that's not cured. One of the things with diabetes insipidus, and I'm telling you, these are registered nurses who've been nurses for a while. They bring a child and put them in my room, and when I was working in the ER, and says, "Oh, this child has diabetes insipidus, so I did a blood sugar, and it was blah, blah, blah." And I said, "It's nothing to do with blood sugars, okay? Diabetes mellitus, diabetes insipidus are apples and oranges, okay? Diabetes insipidus is only fluid balance, drinking and urinating. It's too much diuretic hormone being secreted, okay? So the opposite. Now, DI, you're urinating and drinking like crazy. With SIADH, syndrome of inappropriate anti-diuretic against urinating hormone, okay? So you have all this fluid that you're not urinating anymore. You are just not urinating, you're filling up, your fluid retention, and this makes you feel horrible. You're anorexic, you're nauseous, and it's something that, again, it's can be given these anti um, diuretic hormones. All right. Now, when we talk about fluid balance for any reason, there are some nursing care of. We need to, how do you measure fluid balance in any child, any adult? Daily weights, intake, output, okay? If they're retaining fluids, we're going to water restriction. We're going to go low sodium. And because we know that they're retaining all this fluid, they are on seizure precautions because they can have seizures. Now, thyroid. We know adults get thyroids and hypothyroid and hyperthyroid. Symptoms are really similar. The only difference is that thyroid hormone in children is needed for them to grow properly. It's good for their cognition. Infants born with hypothyroidism will have no stool for the first almost 2 days of life. And it's one of the things they look for, along with cystic fibrosis is the other one. So these are two things that could be no stool at birth. Thyroid function is measured by T3, T4, TSH. Those are the ones that we look at, sometimes calcitonin, and we'll be measuring those in lab tests. Now, when we have a child born with hypothyroidism, sometimes we can go ahead. If it's born with it, we'll deal with it, give them medications for life. Sometimes if it occurs over time, sometimes that might be the one we have to remove. But remember, with all of these types of thyroidism and giving these replacements, we have to be careful that it's really monitored closely. So what would you see in a child? Well, what do we see in adults? Dry skin, sparse hair, puffiness, constipation, lethargy, cold intolerance, right? But in children, the other one will be, their growth, because that's what they need it for. And because we also need thyroid hormone for their mentation, they're not going to be in that growth and development. They're not going to follow the curve. They're going to be behind in many ways. So we give thyroid hormone, we monitor it as well as we can. And how do we monitor that the thyroid hormone is working accurately? Well, we're the drug levels, of course. But again, as I said, it's all about it's good for their height, weight. Well, they're going to measure, are they mentally where they should be? And height and weight. Again, another reason why we always do height and weight on children when we see them. Now, hypertrophy of the thyroid gland, the gland is just way too big. Um, Sometimes it's due to mom, sometimes it's on their own, okay? Now, hyperthyroidism, what they do is they can put them on medication to decrease the amount of hormones to be delivered. But we have to be careful that some of these, we're monitoring it a lot because one of the things that they say with infants, because it's so hard to regulate them, that they get that thyroid taken out at birth and then they'll be on replacements forever. Now, lymphocytic thyroiditis, Hashimoto's, is a disease, it's autoimmune of the thyroid, which means you cannot remove it. This one does not get surgery. This one is usually those late age children and teenagers. My daughter-in-law has it. And what she has to do is frequent checking of her drug levels, and she takes several types of hormone therapies, and they are autoimmune, okay? Lymphocytic thyroiditis, again, is this big thyroid. Again, we're monitoring all the drug levels, is what that is. As I said, they're going to get administration of their thyroid hormone and no surgery for them. Okay, Graves' disease, hyper, too much. Well, one of the things is you might see them, it's usually about 12 to 14 years old that we see hyperthyroidism. Again, we give anti-thyroid medicines, polypropyl, methylprednisolone, and what it does is it blocks that hormone says stop. You not so much, take it easy, and they try to slow it down. Well, one of the things as nurses you need to know is that it can cause leukopenia, means a decrease in white blood cells. So with that, they can have fevers and sore throats. They do say that with this sore throats that call the doctor, hold the results, and we need to teach them. They might take out a piece of the thyroid or they might ablate the whole thing. Again, and Lugol's solution is also used, for the thyroid also. That was one of a HESI question that came out a couple of years back. Now, thyroid toxosis can happen because of too much medicine, or it could just be all of a sudden the thyroid releases a lot of hormones and it causes everything sympathetic, up, 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 up. Heart rate, blood pressure, you get dizzy, tightness in the chest. And what they have to do is give an anti-thyroid drug, like I just said, and a beta blocker, usually Inderal, propanolol, and that decreases it. So it's a life-threatening thing. Even the temperatures go up. You might have 104, 105 fever with this also. So again, teaching families about even hypothyroid children on medications or those with hyperthyroidism, trying to decrease it. They see a heart rate getting bigger, they're getting dizzy, headaches, like blood pressure's up, something they need to call the doctor for, okay? Now, Parathyroid has nothing to do with the thyroid. Parathyroid gland has all about serum calcium. Too much, too little. When you think of calcium, I always think about magnesium. Both of them affect muscle contraction. Okay? Calcium and magnesium. So you're either going to have too much or too little. You either can't move or you're just so spasmed out you can't move. You have paresthesia. Those are the two different types of it. So when you have a child on formulas, they say that formula high with phosphate to calcium ratio tend to have other things, and that can cause problems with the parathyroid gland. Now, the hypoparathyroid, again, it depends on too much or too little, right? But when you don't have enough calcium, what are you going to see? Well, as I said, it's usually that muscle sort of thing, the tetany. You can't move, your hands are numb, and you could have problems breathing because the muscles, right? Isn't a diaphragm a muscle? So again, it affects that. And then, of course, you get into headaches, etc. And again, they're going to need calcium supplement for these children. We give vitamin D to these. Why do you think we give vitamin D drops to breastfed babies? It's part of the calcium vitamin D thing, and it helps keeps these children, breathing correctly, their muscles moving correctly. Okay, and it does. If there's something going on, we give the replacement. They do so much better. Now, hyperparathyroidism. Usually it's a cancer again, too much. And again, it's hypercalcinemia. And one of the things that we should do is usually if it's hyperparathyroid, they're going to remove it. Or if there's something else that's causing it, we're going to treat that. Now, adrenal gland. So we've gone over pituitary, and we've gone over your thyroid and your parathyroid. Now, adrenal glands. Adrenal glands has everything to do with cortisol and aldactone. Cortisol is the internal steroid that you have. And sometimes the adrenal gland gets these, sometimes a tumor, it's called a pheochromocytoma, and it just spews out this cortisol basically, and it creates an elevated heart rate, blood pressure, again, everything up, 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 up. Very difficult to treat. Now, one of the things that can cause the adrenal glands also not to be happy is when, let's say you've been ordered to be on steroids. I was placed on too many steroids for too long, and I had to come off. I took 5 months to come off because I was so scared of going into adrenal crisis, because an abrupt withdrawal is what can cause that. Now, children, it doesn't really happen. We don't have a lot of them on steroids, but we do mention it. And if it's going through it, you just right now, you got to replace that cortisol. You got to get the level back up, and then the adrenal gland will stop. Now, as I said, I had too much steroids. Well, that's Cushing syndrome. Cushing syndrome is that big round face, ruddy cheeks, hair on the chinny chin, acne, red striae, big abdomen, neck, and usually skinny arms and skinny legs is what you see with this. So it's the prolonged steroids. And one of the things is if this child, like me, could get off the steroids, everything was reversible. The weight came off and all of that, whatnot. So it is reversible when the steroids are taken off slowly, slowly. These are all the things that I just told you what this child looks like. They're going to weight gain, big red cheeks, hair growth, big face, pendulous abdomen, red striae. And the other thing is steroids causes poor wound healing, right? So Cushing syndrome, it's too many steroids. So what do we do for Cushing syndrome, Cushing disease? If it's caused by the gland itself, we'll take it out, the adrenal gland. If it's steroids, we are going to decrease them off. Now, there's different places in the body for steroids and the adrenal gland. One of the things that can happen with children is that we can have not enough endogenous steroids and cortisol produced, and we can have a child that's going to be neither a boy or a girl. And at birth, we got to make a sex assignment. This here looks like a clitoris with testes. There could be a vagina in there, or maybe that's a small penis, but all of the stuff doesn't match. What happens with these children is that we need to, and it's called an ambiguous genitalia. And what we need to do is figure out what we are going to make these children. Are they a boy or are they a girl? Usually, what they do is they'll do a hormone test, they'll do ultrasounds, they'll figure out what sex would be the best for them, and they do reconstructive surgery. But can you imagine a parent having a child, not knowing if it's a boy or a girl? So, nurses, this is where we come in, to give them that comfort because they're afraid they're going to make a wrong decision because of what's out there today, documentaries, right? We've all seen them. And I mentioned the pheochromocytoma, and that's your adrenal tumor, and that's what can cause these sporadic, elevated, sympathetic type of happenings. It's catecholamine, which means up, 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 everything, and very difficult to diagnose because when you talk about elevated heart rate, and you talk about elevated blood pressure, aren't you thinking more cardiac? So they do huge cardiac workups. And then finally, they do an ultrasound or CAT scan of the abdomen and they find the tumor and they can remove it. Now, let's go in now to the pancreas. It's another hormone producer, right? Produces insulin. We know that diabetes mellitus, there's type 1 and there's type 2. Children, young children are type 1 and will always be type 1. They don't convert to type 2 when they get older. Once you have no insulin or minimal produced, it's the same thing. Hypoglycemia, jittery, sweaty, dizzy. What do we give kids? Well, we give them orange juice, we give them milk, if that's what they'll drink, something with sugar in it, and then make sure we get some protein to them. Type 1, as I said, it's more in the younger children. A lot of adolescents are type 2. So that's where I said the breakdown is we're type 1 or type 2. We know type 2 is usually later on in life, does not mean always. And we know that the Native American, Hispanic, African American are at increased risk for it. So again, these children will need medications and they'll be placed on insulin. Many times they put older, like mid-school age children, they'll give them an insulin pump. And they stick one needle in, they put a good bandage on it to cover it, a dressing, and then it's a continuous flow. So only one stick, and we teach these children how to use it. Now, what is diabetes? Simply this. Diabetes is the pancreas does not secrete enough insulin, so the carbohydrates that you take in can't be used. When they can't be used, the body said, boy, I'm hungry. What am I going to do now? I don't have sugar. So it goes, eats the protein and the fats, and that's their diet. Now, that glucose is still there, the carbohydrates. That's why you have elevated blood sugars because the body can't use it. And then with the fat and the protein, it breaks down and it forms ketones. So here we go. Ketonuria, because not enough insulin, too much carbohydrates, blood sugars elevated. And that's why that happens. So diabetic ketoacidosis, these children, and I've taken care of quite a few in my lifetime, they come in pale, they come in dehydrated, they come in very drowsy, usually even the teenagers in a wheelchair. They can barely walk. And I have seen blood sugars of 1,000. I have seen a pH of 6.8, which is not congruent with life. And the children made it because they got there just in time. And what do we do with these children? It is dehydration, electrolyte imbalance, right? Give them fluids, priority. And second, a regular insulin continuous slow infusion, monitoring blood sugars frequently. Now, one of the quick things we do before we even do labs on these children, we can smell it. That acetone breath or fruity breath, whatever you want to call it, smells like you took a peach, put it in a container with a top on it and sealed it, forgot it in the refrigerator for 2 months, took it out, took the top off, and you smell rotten sweet. That's what these children's breaths smell like. And once you smell it, you'll never forget it, okay? So, in DKA, the body's not using sugar. They don't have enough insulin for whatever reason. They're becoming dehydrated. You are going to see ketones in their urine. When we look to confirm diabetes mellitus, we're going to be doing a blood sugar, and they say children, it's 126 and higher. In adults, it's 100. We're also going to see also a hemoglobin A1C. They say 6.5 or more. You know, in adults, they start at 6. So they give children a little bit of leeway there. Treatment is insulin. It's also monitoring blood sugars. It's also following those hemoglobin A1Cs because they measure the last 3 months of their sugar to see if they're in control or going up and down. Children I have seen use their insulin pumps. They push the little buttons when they need a bolus. We do a blood sugar, we find out what it is, and they are amazing. I've seen 7-year-old kids use it and do really good. They need to know signs of hyperglycemia. They can smell it. I mean, sugar is oozing on them. And then hypoglycemia, that sweating, that dizziness. And then what do we do for the sweating dizziness? They're alert, give them something to drink. If they're not alert, that's when you do D50 or glucagon. With these children, they need to make sure that they have good hygiene. Just like adults, they can get sores that don't heal as well as they should. So wearing shoes, brushing their teeth, all of these things are very, very important. And of course, we need to support the child and we need to support that family. It is a lot to deal with. So a nasal spray of desmopressin, DDAVP, is used to treat which of the following? It's 2 of them.
Diabetes insipidus.
Yes.
B.
And last week I told you hemophilia. So a lot of stuff. What I want you all to do, I want you to also look at the Kahoots that I sent. I'm going to send it in the recording also. It just reinforces what I just said, breaks it down a little bit for you more, and helps you understand. It's a lot of information, a lot of hormones coming from many different areas in the body. Anybody who wants to meet with me, go over it, please. Just make an appointment and I'll work around your schedule. Okay? Exam grades are going to be out Saturday about 1:30. Again, you know, I'm looking at every question, making sure that you all are getting a fair test. So we know that one question is going to be gone. Thank you, DC. You all have a good evening. That's it. That's all I have.
Thank you. Have a good night.
Thank
Yep.
you.
You're very welcome.
Thank you.